Dr. Mala Srivastava is here with us. She is a well-known and eminent gynecologist. She is senior consultant and professor, gynae endoscopic and robotic surgeon at Sir Gangaram Hospital, New Delhi. She is the vice president-elect of ISOPAB 2023 to 24, and also has been the past president of AOGB from year 2020 to 2021. Her areas of interest are gynae oncology, gynae endoscopic surgery, and gynae robotic surgeries. She has been trained in robotic surgery at France. She has been on the governing council and has been executive member and chairperson of various committees. She is the recipient of various awards, including APJ Abdul Kalam Excellence Award, Dr. Subhash Mukhopadhyay Women's Health Icon Award, and the Women Medical Professional Award by Ayushman Bharat. She has been the chairperson of Cervical Cancer Awareness and Prevention Committee of AOGD from 2016 to 2019. It is my pleasure to invite Dr. Mala Srivastava. She will be delivering her talk on epidemiology and recommended guidelines for cervical cancer screening. Over to you, Dr. Mala.
Thanks, Dr. Pooja, for your nice introduction. As Madam has already told, cervical cancer is the fourth most common cancer in women worldwide. It develops slowly, but it has a long off period with precancerous condition. And precancerous lesion of cervix can be easily detected by cytological examination, either conventional pap smear or by LBC, and this condition is completely treatable. The global estimate of cervical cancer is 604,000 new cases every day and 342,000 deaths in 2020. And about 90% of the new cases detected and the deaths detected in 2020 occurred in low and middle income countries. And we all know HPV type 16 and 18 are responsible for most of the high-grade cervical precancer lesions. Women living with HIV are again 6 times more likely to develop cervical cancer compared to women without HIV. And moreover, in all the world regions, the combination of HIV to cervical cancer falls disproportionately on younger women. And what is India's perspective? Current estimates indicate that every year, India has 123 women who are diagnosed with cervical cancer, and 77,000 women die from this disease. Cervical cancer ranks as the second most common cancer among women in India. As Madam already told you, in the metropolitan cities, it's the breast cancer which is first, but in some of these areas, still cervical cancer is first on the list. So cumulative, India has first breast cancer and then cervical cancer. So about 5% of women in general population is estimated to harbor cervical HPV 16 and 18 infection at any given point of time. And 83% of invasive cervical cancer are attributed to HPV 16 and 18. So cervical cancer mortality in India is 12 per 1 lakh per year. There is a lack of organized cervical screening program. That is why the disease burden is high in India. Now there is an intense need to standardize the screening, diagnosis, and management of pre-invasive disease of the cervix. What are the methods of screening? Cervical cytology, both by conventional pap smear as well as liquid-based cytology. Visual methods, via and villi, HPV testing. This is how pap smear is taken, liquid-based cytology, via as well as HPV. What is the prevalence of HPV? The lifetime cumulative risk of HPV infection is greater than 80%. Most genital HPV infections are transient, with a persistent rate of less than 10% for infections with high-risk HPV, which are associated with pre-invasive and invasive lesions. It was found that 10% of women with normal cytology were detected with either high or low-risk HPV types. The highest HPV prevalence being in sub-Saharan African, Eastern European, Latin America, and lowest in Northern America and Western Asia. As ma'am also pointed out, in India, the prevalence is lower to the range of 7%. ranging from 6 to 12% in most of the studies. What is the overview of the screening test? VIA, it's simple, inexpensive, easily available, requires brief training, requires minimal infrastructure, results are immediately available, and you can do screen and treat at the same sitting. The limitation is requires quality control. Interpretation is subjective and is not good for postmenopausal women. And of course, it has low sensitivity. Regarding cytology, it has a proven effectiveness to decrease cervical cancer in repeated rounds of screening. Widely accepted training and methods are well established, and definitely it is highly specific, 93%. Only limitation, it requires good infrastructure, requires transportation, how you collect the sample, how you transport, and how the slides are made. It depends on that. Quality control and quality assurance has to be there. Interpretation is relatively subjective. Relative results are not immediately available. And of course, it has less sensitivity. HPV DNA test is relatively simple. Assay result is definitive and endpoint, and also requires brief training. What is the limitation? Requires minimal infrastructure, requires quality control, quality assurance. Results are not immediately available, and of course, it is less sensitive. So what is the performance characteristics of different screening methods? Conventional cytology, moderate sensitivity, but highly specific. HPV DNA testing, high sensitivity, but moderate specificity. And when you do co-testing, it combines the benefits of both. What about the visual methods? VIA, VIA-M, and VILI all have moderate sensitivity, but low specificity. As ma'am have already told, primary HPV testing has replaced cytology in the cervical screening programs in various countries, including Australia and parts of Europe. However, it cannot differentiate between persistent or transient infection. That is why it has 3 to 4% lower specificity than cytology. And it is not recommended in the women aged between 21 to 29 years because these women have high prevalence of infection, which is cleared off by their own immunity within a short span of time of 1 year or 1.5 years. HPV test is also more sensitive than cytology in post-treatment follow-up. So how do we choose resource-based cervical cancer screening recommendation? If we have a good resource setting, the modalities are either HPV testing, either primary testing or co-testing. With cytology, we can do cytology as alone or VIA also. But in limited resource setting, VIA is the answer. And if we can shift to affordable HPV testing, that should be introduced if feasible. Target age group for good resource setting is 25 to 65 because cytology we start at 25 years and we stop at 65. But when we are talking about VIA or HPV, we start at the age of 30 and then we stop at 65. But in postmenopausal patient, it is difficult to screen with VIA. Of course, with cytology, we are starting at 25 years and co-testing at 30 years. And frequency, cytology every 3 years. With co-testing or primary HPV testing, it is every 5 years. When we talk of VIA, we have to start at the age of 30 and every 5 years. At least 3 times in a lifetime of a woman, if we can do VIA, we can prevent cervical cancer to a great extent. Again, when is the age to stop screening? 65 with consistent negative results in last 15 years. Women with no prior screening should undergo test once at 65 years and if negative should exit screening. But in our clinical practice, we get women of the age of maybe 70, 76 who never had cytological screening throughout their lifetime. And whenever we get reference for any cause, postmenopausal bleeding or discharge or whatever, we take the opportunity to do at least LBC or cytological screening for that woman at least once in a lifetime. But then Our recommendation is not there, but it's a part of a clinical practice, because every woman should have at least once screened for cytological screening for pap smear or LBC for cervical cancer. What about the follow-up method after treatment? If the patient had treatment, then we should do HPV testing or cytology at 12 months. And if we have given treatment and we want to follow up with VIA, again, that has to be done at the end of 12 months. Screening following abnormal reports more than CIN2, irrespective of method of treatment, should be continued for another 20 years. What about screening in hysterectomized women? Following hysterectomy, in which cervix was removed for benign causes, no need to screen unless there was a history of previous CIN. Absence of cervix must be confirmed by clinical records or examination. If indications of hysterectomy is not clear, then screening may be performed at clinician's decision. If the patient had history of CIN in hysterectomy HPV report, then she needs to be screened with HPV or cytology at 6 months and 18 months minimum. Screening of immunocompromised women. Start within 1 year of initiation of sexual activity. Suppose a patient is HIV positive, you have to start within 1 year of initiation of sexual activity. So far as cytology is concerned, we say in a normal immunity patient, you start at least 3 years after the initiation of sexual activity. But nowadays they are saying 25 years for cytology, 30 years for HPV or VIA. We should be familiar with Bethesda system for reporting cytology. NIM negative for intraepithelial lesion or malignancy. Ascus, a typical squamous cell of undetermined significance. As H, a typical squamous cells cannot exclude high-grade squamous intraepithelial lesion. L-cell, low-grade squamous intraepithelial lesion. H-cell, high-grade squamous intraepithelial lesion. SCC, squamous cell carcinoma. AGC, a typical glandular cells. If we write NOS, not otherwise specified. AGCFN, that means atypical glandular cells favoring neoplasia. AIS, cervical adenocarcinoma, and C2. Endometrial cells in women more than 40 years of age should be investigated, and others are adenocarcinoma. So screening with primary HPV testing in women aged more than 30 years. How do you do? If HPV test is negative, you go do 5-yearly screening protocol. Now, if HPV test is positive, you have to do either VIA, cytology, or HPV genotyping if you have the facilities. If VIA is negative, that is visual inspection with acetic acid is negative, then repeat HPV test at 1 year. If it is negative, we return to 5-yearly screening protocol. If it is positive, you must do colposcopy and cervical biopsy. If VIA is positive, HPV is positive, you have to do colposcopy and cervical biopsy. If HPV is positive, cytology is more than ascus. Again, we have to do colposcopy and biopsy. If it is NILM, repeat HPV test at 1 year. When HPV is positive and we have facility for HPV genotyping, if it is genotype is 16 or 18, we have to do colposcopy and biopsy. We should have low threshold for doing colposcopy and biopsy. If it is other type of high risk HPV, then we can repeat HPV test at 1 year. If it is negative, we can return to 5-year screening. If it is positive, then we have to confirm it by colposcopy and biopsy. Screening with co-testing with women more than 30 years. How do we do it? HPV negative, cytology negative, 5-year screening. HPV negative, cytology positive. If it is as H or HCIL, colposcopy and biopsy, we must confirm the diagnosis. HPV negative, cytology positive, ascus or LCIL, we have an option of doing the repeating co-testing at 1 year. If it is negative, both are negative, we can return back to 5-year screening. If one is positive, that is HPV is positive or cytology is more than ascus, we have to do colposcopy and biopsy. HPV positive, cytology negative. If facilities are there, we must do HPV genotyping. Again, if it is 16, 18, directly we go for colposcopy and cervical biopsy. Then we don't take any chance. If HPV genotyping says other than 16, 18, high-risk HPV is positive, we can repeat co-testing at the end of 1 year. Both negative, return to 5-year. One positive, either HPV or cytology, we go for colposcopy and biopsy. Screening with cytology of ascus in women more than 30 years. Ascus, if we have facility for HPV testing, we do it. If we don't have the facility for HPV testing, we repeat cytology at 1 year. HPV test negative, 5-year screening. Positive, colposcopy and biopsy. But in some centers, they do not repeat cytology at 1 year. If they think the patient is non-compliant, will not come for follow-up, they do colposcopy or via and do see and treat. This is the method nowadays in low resource setting and in camp-based, when there is a lot of population and we think that the patient will not come back follow-up, will not comply, they do see and treat method. Ascus cytology at 1 year negative, return to routine 3-yearly screening. Ascus or LCIL, colposcopy and biopsy. Ascus or HL, as H or HCIL, then we do colposcopy and biopsy. If it is LCIL more than 30 years, then again we do HPV test positive, that means LCIL and HPV positive, colposcopy. Negative, then we do co-testing at 1 year. Because if one of them is negative, maybe we can LCIL more than 30 years, maybe we can repeat HPV testing at the end of 1 year. If both are become negative, co-testing at 3 years. Again, if the cytologies persist as ascus or HPV comes as positive, we go for colposcopy and cervical biopsy. Some settings, when they think that patient will not come for follow-up, they do direct colposcopy or biopsy or direct see and treat procedures. Screening with cytology management of ascus or LCIL in women less than 30 years. Now, when the women is less than 30 years, there's more chance that they will be having infection with HPV, but their own innate immunity can clear off this infection within a span of 1.5 years or 2 years. So if a woman is less than 30 years, ascus or LCIL, we repeat cytology annually for 2 consecutive years. NILM, repeat cytology at 3 years and return to routine screening. If it is persistent as more than ascus for 2 consecutive occasions, then definitely we have to address it by colposcopy and cervical biopsy. If it is normal, colposcopy and biopsy is normal, then we can return to routine cytological depending on their age. If it is abnormal, then we have to follow the guidelines of management. Screening with cytology, management of HCIL in women aged more than 30 years. When there is ASH, high-grade lesion cannot be excluded. We have to have a low threshold for colposcopy, cervical biopsy, and maybe endocervical assessment. If we can see the entire transformation zone, lesion is less than CIN1, we can either do ablation treatment or co-testing at 1 year. CIN2 and 3, we do LEAP, treat the patient, see and treat. If the transformation zone is not completely seen, colposcopy is inadequate, diagnostic excision has to be done. Screening with cytology management of ASH or HCIL in women less than 30 years and desirous of pregnancy. Now, the women is less than 30 years. We know that there is high incidence of HPV infection, which they can clear off. But now the patient is SH or HCIL. Again, we'll have to have low threshold for colposcopy and biopsy. We cannot wait for these women to advance. So we will do a definitive colposcopy and biopsy and address this women. No CIN2 and 3, repeat cytology and colposcopy 6 monthly for 2 years. Low threshold, repeated cytology, repeated colposcopy. If HSIL persists for 1 year, again we do cervical biopsy. No CIN2, 6 monthly follow-up. But if there is CIN2 and 3 to begin with, then we have to follow the guidelines depending on the patient requirement, patient desire, and the amount of the lesion. We have to address this patient with CIN2 and 3. We have to do some excisional biopsy, cone biopsy, leaf biopsy, whatever. Screening with cytology, management of abnormal glandular cells, atypical endometrial cells. We have to address this. We must do endometrial sampling or endocervical curettage, and depending on the pathology, we have to address. Screening with cytology, management of abnormal glandular cells, AGC not otherwise specified, or atypical endocervical cells. We have to have low threshold for colposcopy, biopsy, endocervical sampling, and endometrial sampling. If there is no CIN2, no AIS or cancer, we have to repeat co-testing or cytology at 1 year, then 2 years, and then keep a close follow-up of these patients. If persistently the test is negative, then we can return to routine screening. If any time any test is positive, we have to keep a low threshold for colposcopy and biopsy. If on colposcopy and biopsy, we find more than CIN2, AIS, then we have to follow definitely management guidelines for these patients. Screening with cytology, management of abnormal glandular cells favoring neoplasia or AIS, low threshold for colposcopy, endocervical sampling, endometrial sampling, and depending on the pathology, we have to treat. What about unsatisfactory smear? Nowadays, we get very less unsatisfactory smear in our hospital because we have shifted to LBC. But when we were doing conventional pap smear, sometimes we used to get unsatisfactory smear. Then in that case, we have to review the HPV report if available. If it is negative, we can return to routine screening. If it is positive, then we have to follow the guidelines. Unsatisfactory, if HPV test is not available and the woman is less than 30 years, we repeat cytology in 2 to 4 months. We repeat it frequently after giving the treatment for local infection or whatever, because we cannot allow these patients to be lost to follow-up. Again, it is unsatisfactory, then we do colposcopy. More than ascus, we follow the guidelines. NILM, return to routine screening. If the pap smear is unsatisfactory, we complement it with VIA. If it is negative, return to routine screening. Positive, then we follow the guidelines. Screening with VIA in women aged 30 to 65 years. VIA negative, VIA is done at the end of every 5 years and minimum 3 times in their lifetime. That should be the aim. But if possible, if we can do every 5 years VIA, nothing like that. If it is VIA positive, then we have to see what other screening methods is available. Otherwise, we can do colposcopy and cervical biopsy. And depending on this lesion, it has to be either observation, ablation, leap, or whatever. CIN1 on histology. We think that we have done hysterectomy or we have done a biopsy for benign condition, but it has come as CIN1 on histology. What to do? If possible, we can check the reports of HPV cytology via report. If HPV was positive or it was ascus or LCIL or VIA positive, then we have to do co-testing with HPV cytology VIA at 1 year and 2 years. If the test becomes negative, we can return to routine screening. If we check the preceding reports, it was ASH or HSIL, then again we have to do co-testing at 1 to 2 years or cytology at 6 months. Any test positive, we have to do colposcopy and biopsy. Women with CIN1 on histology desirous of pregnancy. What to do? We have to check preceding cytology report. Ascus, LCIL, repeat cytology at 1 year. Cytology, more than ascus, colposcopy and cervical biopsy. Cytology, NILM, return to routine screening. SH-LCIL repeat cytology colposcopy 6-monthly interval, low threshold for colposcopy and cervical biopsy. CIN 2-3 on histology, review colposcopy report, and here we have to have more aggressive management. It is not only colposcopy, we may have to do conization, LEEP, remove the transformation zone, etc. Management of women with CIN 2 or 3 on histology, desirous of pregnancy. What to do? Cytology, colposcopy at 6 months. We can triage with P16, Ki67. CIN 3 with inadequate colposcopy, excisional procedure. If we triage with P16 or Ki67, if it is negative, maybe colposcopy every 6 months and cytology is all right. But if it is positive, then we have to go for excisional procedures. There are newer modalities, cytology-based screening. Thin prep, LBC in our hospital, we are doing it regularly. Biomarkers, P16, INCA4A, CIN Tech Plus. And these biomarkers, they identify transforming HPV infection, detect CIN2 and more disease, triage low-grade smears, can be done with histology and cytology slides, reduce colposcopy referrals. Of course, these biomarkers, sensitivity is only 64 to 92%, and specificity is also 41 to 96% for low-grade smears. Limitation, wide variation in reported sensitivity, lack of standardized reporting, need for substantial expertise. We are routinely doing LBC in our hospital. We get lesser inadequate pap smear, reflex HPV testing is positive, automated reading positive. Sensitivity is not better than conventional, but sensitivity for LCIL and lesion are more expensive, but we have definitely switched over to liquid-based cytology in our hospital. There are other newer modalities, HPV-based screening by E6, E7, mRNA, DNA methylation, and markers of aberrant S-phase induction, vaginal self-collection. They have their own plus and minus points. Management of women with CIN in pregnancy. You have to do colposcopy in every trimester. AIS on biopsy, conization to rule out invasive disease. What is the criteria for see and treat? In the colposcopy clinic, when we see the patient will not come for follow-up, we see and treat, screen and treat in public health programs. WHO has given 90-70-90 slogan to us, the path to eliminate cervical cancer. 90% prevention through vaccination, screening of precancerous lesion, and timely treatment and care. We hope we can have cervical cancer Mukt Bharat in near future, maybe by 2030. To conclude, cervical cancer screening guidelines have changed dramatically over the last 15 years, following introduction of testing for the high-risk HPV types, which cause virtually all cervical cancer and its precursors. HPV testing is the most sensitive method for screening of cervical cancer. Primary HPV testing using standardized test can be preferred over co-testing with an option of self-sampling to improve coverage. Thank you for your patient listening.
Thank you, Dr. Mala, for this very comprehensive and enlightening talk. And I'm sure the audience and delegates will take back a lot of take-home messages from this.